You let me know when record is on because I can't see that button from here.
Okay, ready to go.
All right. Okay, good morning. Welcome to September 2021 Clark EMS PCEP. Today we're going to talk about stroke, updates on stroke, and also revisit and discuss a little bit about the pandemic treat and release protocol. So, as we all, stroke is one of the biggest things that EMS deals with. The mortality from stroke in the United States is about 140,000 people per year. It went up slightly over the last several months with COVID, as COVID was implicated in increasing the number of strokes by increasing some clotting factors. So stroke mortality is in the United States, 1 out of 20 deaths is from stroke. That's a total of about 800,000 strokes per year in the United States, but 610,000 of which are new strokes. In other words, 200,000 strokes are the second or third stroke someone's had. Most strokes are ischemic, about 87%. Stroke is a leading cause of serious long-term disability. In Clark County, the number of strokes we see per month and transport to the two hospitals far exceeds that of the cardiac arrests and myocardial infarctions that we're dealing with. So strokes are classified as ischemic stroke. They can be either occlusive, either caused from a thrombosis de novo in the cerebral circulation, or from an embolism, which is, of course, an embolism is a clot that originates somewhere else. Generally speaking, the most common cause is originating from the mitral valves, particularly in cases of atrial fibrillation. And it's just simply bad luck that that thrombus goes uphill to the brain instead of downhill to the kidney or some other less critical spot. Also, you can have embolisms that are septic in nature. These are the lesser numbers of occlusive strokes. Now, the anterior circulation, you get occlusion of carotid artery branches, most commonly the middle cerebral artery. And in the posterior circulation, you get either vertebral or basal artery stroke occlusion, which results in typical signs and symptoms of posterior circulation. Hemorrhagic strokes, subarachnoids, the most common is from aneurysms. Less common, but not to be missed, is arterial venous malformations, which are basically a abnormality of the circulation in the cerebrum, which allows the artery to directly connect to a vein without having an interposed capillary system, which allows arterial pressure to push on the vein, which causes it to dilate, which causes it to rupture. So in a way, it's a type of aneurysm. An aneurysm is a defect of the intima of the artery itself. So the artery under pressure begins to balloon out, and ultimately the aneurysm can rupture. Intracerebral hemorrhage is very common, especially associated with hypertension and with changes in the media of the arteries in the elderly, which is called amyloid angiopathy, which means that the artery becomes quite fragile and will rupture. Now, signs and symptoms of stroke are kind of varied, but there are some very specific things. We're talking mostly ischemic stroke here, which is the vast majority of strokes. And the carotid circulation involves the largest proportion of those strokes. And typical of carotid circulation are paralysis. It's unilateral, and it's involving the opposite side. So if the stroke is on the left side of the brain, the person is paralyzed on the right side. Numbness also is contralateral, so it's the opposite side gets involved. Now you can have numbness without paralysis, and vice versa. Language disturbance.
Strummer. Hey, is Ray there?
Can somebody mute?
Get the PCEP test. Okay, no big deal.
Language disturbance, which we just had a form of, but not the kind we're talking about. With strokes, aphasia is difficulty in comprehension. They may speak nonsense words, difficulty in reading and writing. Dysarthria means slurred speech, abnormal pronunciation. So all of those things can be, so aphasia is a particularly problematic thing to, if you survive a stroke and you're aphasic, that's more than life-changing. Visual disturbance in the ischemic, in the carotid circulation, any visual disturbance is usually presented on the opposite side from the stroke itself. But monocular blindness, so one eye being blind, that occurs on the same side, and that's generally due to an occlusion of the arteries supplying the optic nerve itself. Now, in the vertebral basilar circulation, the hallmark signs are vertigo, type of dizziness. Vertigo is rotational motion sickness. You're moving without, you're spinning around without actually spinning around, and or sort of total loss of balance and loss of being able to walk or function because of that loss of balance. Both eyes are affected with visual disturbances. You can often have diplopia, which means that that you see double vision because of one eye is difficulty moving from one side to the other, or there's an asynchronous movement known as disconjugate gaze when one eye, when your eyes don't track together. Paralysis can occur also with vertebral basilar circulation strokes and numbness. It's a little different than what you see in anterior in the cerebral, the anterior cerebral and middle cerebral strokes. Dysarthria means difficulty in walking, and ataxia is literally so so uncoordinated you cannot essentially walk, function. Now, signs and symptoms of hemorrhagic stroke are a little bit different. Typically, with the subarachnoid hemorrhage, it's a sudden, severe headache, possibly a transient loss of consciousness, then nausea and vomiting, neck pain, so you have signs of meningeal irritation from the blood in the subarachnoid space. In more severe cases, they're intolerant of noise or light, like a severe headache. It's usually the worst headache they've ever had. That's what they will tell you. And then they may have altered mental status. They may everything from semi-comatose to not to just being not their quote not their usual self. One of the characteristics of subarachnoid hemorrhage has been that often the preliminary bleed is very minor or relatively minor, and the patient after a few days gets better, almost well, and then without treatment and evaluation, they may have a sudden severe secondary bleed, which is life-threatening and or will cause profound cerebral damage. Intracerebral hemorrhage will have focal symptoms.
Jeezy, you're muted.
How about now?
There you go. Perfect.
I don't know how that happened because I didn't touch anything. What was the last thing you heard?
Focal signs with an intracerebral hemorrhage.
Okay. All right. So often a history would be that the person is found in bed with comatose, hypertensive, and with Cheyne-Stokes type respirations or abnormal breathing, and this would be a typical sign of intracerebral hemorrhage and or presentation, and that person needs to go to a place where at least they could have neurosurgical evaluation, which is Peace Health Southwest for us. I'm not moving ahead now. Are you still hearing me?
Yeah, I can hear you just fine. Click on the slide and see if you can get the controls to show up in the bottom left corner.
I'm not getting anything to show. So I'm not sure why this is frozen.
Try page up. There you go. Now you've got it. So see the right arrow down in the bottom left-hand corner of your slide? Click the right arrow.
I don't see it.
Oh, there you go.
That move? Okay, I'm moving ahead with the mouse now. Okay, so are you still hearing me and we're moving ahead?
Yes.
Okay, differential diagnosis of stroke, quickly. We'll try to catch up here. Head and cervical trauma, meningitis, encephalitis. So can give you symptoms similar to a stroke. Hypertensive encephalopathy. This is essentially pre-stroke. You're getting the same effect as you would if you actually had the complete damage caused by an intracerebral hemorrhage. Intracranial masses, tumors, subdural hematomas, epidural hematomas can all mimic stroke symptoms. Todd's paralysis, a fascinating thing. It's a seizure, and then you have a brief period of temporary paralysis, and it mimics a stroke because it's you're paralyzed on just one side of the body. Probably indicates that that motor area of your brain was stunned for a while. Now, when we say brief period, this can be as long, in my experience, as 24 to 48 hours. So during that time period, we have to assume that the paralysis was due to the seizure and not due to a stroke, which is now with good imaging, we could probably help to rule that out. Migraines sometimes have numbness, one-sided numbness, facial numbness, particularly one-sided, even one-sided paralysis associated with a severe migraine. Then, as we all know, both hyper and hypoglycemia can be confused with stroke, and we have to rule out, which is why your orders require always doing blood glucose on any potential stroke victim. Post-arrest ischemia often presents, often the patient is everything from comatose to having other neurologic findings, including hemiparesis or complete paralysis. Drug overdoses, of course, could mimic some of the signs of a stroke. Differential diagnosis, our old mnemonic AEIOU tips. We have to rule out acidosis, alcohol, endocrine causes, including epilepsy, electrolytes, encephalopathy, infection, particularly sepsis. Lots of times sepsis presents as apparent paralysis or apparent, and of course, coma, altered mental status. Opiates overdose, uremia, trauma, hyperglycemia, poisoning, various medications, and psychosis. There's such a thing, there's surreptitious paralysis that's due entirely to psychosomatic illness. Strokes, and then of course strokes, seizures, syncope. Now we localize, when you look at the cerebral circulation, stroke frequency is greatest in the middle cerebral artery, which is where we always have in the past concentrated a lot of our attention. So mid cerebral artery is 60% of all strokes. Anterior cerebral artery, that's a tiny fraction of the strokes, 2%, almost. It's hard to pay too much attention to that. Vertebral basilar, which is a much higher, 15 to 20%, really is where we have learned to concentrate a lot of our activity now. And then the lacunar syndromes, which are little strokes in little small areas, disparate areas of the brain, which are generally associated with the elderly, and usually usually causes changes in mentation rather than profound any paralysis. May cause some abnormalities in gait and things like that too, but mostly it's associated with sort of the onset of aging dementia. Now, this is a depiction of the cerebral circulation at the level of the going up from the brainstem up into the pons, up into the medulla, and then the branches going up into the cerebrum, the cerebral cortexes, which are above the anterior portion at the top of the screen. So the very front, you have your anterior cerebral artery and the ophthalmic artery, what we like, the circle of Willis, which connects the anterior circulation with the posterior circulation. There's the middle cerebral artery as a branch of the internal carotid artery. There are choroidal arteries, which are going to feed the brainstem itself and the pons and medulla. Then you get into the posterior cerebral circulation, which starts with two spinal arteries, which are vertebral arteries. And then it comes together into one artery called the basilar artery. Important things off this are the posterior cerebral artery, which is fed by the circle of Willis and by the basilar artery. The pontine arteries going to the pons, the anterior inferior cerebellar artery, the labyrinthine artery, which is also called the internal auditory artery, and that feeds the labyrinthine structure of the ear, which is why you get vertigo. And then the posterior inferior cerebellar artery, also known as pica, which obviously feeds the cerebellum. Now, the whole point of the circle of Willis is to keep circulation going to the important parts of the brain. It can go antegrade or retrograde, depending on issues. So if you only depended on the basilar artery to feed the posterior the pons and medulla, every time you maybe bent your neck severely, or if you had arthritis and you squeeze and it pinches on the vertebral or basilar arteries as you bend your neck, or if you have minor occlusion, you would shut off the circulation to the midbrain and brainstem, and that obviously is not good. So, but with the circle of Willis, you get to feed the posterior circulation from the anterior circulation. Also, the reverse works. So you can this is a kind of a safety valve. It's like having collateral circulation that helps keep your heart going well. So if you have a minor occlusion, it can still be fed by another artery. Now, as we get older, of course, the big problem is you get plaques and you get disruptions, narrowing of these arteries, and that's where we begin to have potential for stroke issues. So anterior carotid or anterior cerebral artery strokes occur in only 2%, and when they do present, you'll have contralateral, opposite side, weakness of leg, and opposite side sensory loss. That's not it's weakness and sensory loss. It's not full paralysis, but it's hemiparesis, and it's opposite the side of the stroke itself. Now, middle cerebral artery strokes, the big money, 60%. Hemiparesis, face and arm more than the leg. That's why we ask you to check arm drift and arm and facial grimace, facial droop more than we do checking the leg. Hemisensory, face and arm more than leg. Hemianopia, which means loss of 1/2 of your visual field. So if you were to look at 2 eyes, it'll be the exact same half that's lost. So temporal on one side, nasal on the other side, but it's 1/2 of the vision that's lost. Gaze deviation, which means that one eye will or you're looking one directional. You can't look left, you can look right only. If it affects the dominant hemisphere, which for most of us is the left hemisphere, then aphasia can occur. Now remember, then aphasia could mean you can't speak, you have mumbled, garbled words, nonsense words, or you can't read and you can't write, you can't read. It could be any part of that. Generally speaking, you've seen it many times, I'm sure, that the patient just cannot seem to find the words, or you can't understand their words. If it's in the non-dominant hemisphere, so the right hemisphere for most of us, there's an odd thing which is called hemispatial neglect, which means they don't seem to notice that they're paralyzed on the left side. They completely ignore it, which doesn't make any sense, but that's it. It's obviously a big issue. Now, the posterior cerebral artery, you get this because this is now affecting at below the circle of Willis. Am I still talking?
PCEP.
Contralateral homonymous hemianopia. Now that's a big word. Which means that it's the opposite side. So if it's a left-sided stroke, cerebral stroke, then your hemianopia, your half blind, occurs on the opposite side. So it's on the right side of your visual field in both eyes. Now, if it's severe, you can also have what's called cortical blindness, where you're totally blind in your eyes because you cannot, because it's occurring at the level of the optic portion of your cerebrum, and so you are totally blind and permanently from that. Now, Anton syndrome is they deny blindness, which of course is kind of hard to understand. It's sort of the extreme of avoiding the fact that they're paralyzed. They obviously can't get around. They'll walk into a wall. But they say they can see just fine. So that's an important. We've had a couple of patients in the last couple of years that were blind and the only but denied that they were and it was picked up by the emergency physician who did a visual field exam, and they couldn't see anything. Now, basal artery is a lot of things can occur. Now, cranial nerve palsies, so mostly involving face, involving the tongue, involving eye, extraocular muscles. So you get facial palsy, which means to droop on one side, gaze palsy. 1.5 syndrome is kind of an interesting thing, which means that one eye is fixed and the other eye can track, but poorly. Severe dysarthria, so extreme difficulty with talking, with swallowing, often with some dizziness. Locked-in syndrome, which is a very unusual thing. It means that a vertebral artery has been occluded at the level of the pons, and patient is intact. They're conscious, they have sensation, they have facial paralysis, and quadriplegia, total. It may even be so. I mean, they're totally quadriplegic, totally paralyzed, but they have preservation of only vertical eye movements, so they can look up and down, and they can open their eyes. So that's why it's called locked in. They're sort of locked in this position, and that's a permanent situation. A Wallenberg Syndrome, which is the pica, which involves the posterior inferior cerebral artery. They get same-sided facial sensory loss, opposite side body sensory loss, same-sided ataxia, which means if it's on the left side, they'll fall to the left. They'll be totally uncoordinated on the left. Same-sided nystagmus associated with vertigo, with true spinning dizziness, a hoarse voice because it affects their vocal cords, and a same-sided Horner syndrome, which is a small pupil that doesn't react usually, drooping eyelid on that side, and absence of sweating on that side of the face. So sort of a theme of posterior circulation strokes is cross findings, whether they're motor or sensory, eye findings, particularly eye motor findings. They will have problems with diplopia because their eyes are not tracking together, which is different than in the middle cerebral, where you had fixed gaze. Vertigo, spinning, labyrinthine type dizziness. Ataxia, they will stumble, they will trip, they will fall, they cannot get about, they can't do a finger to nose test because they're not able to coordinate their muscles with their eye findings and their balance. And you can have quadriparesis associated with posterior circulation as well. Identification of posterior circulation requires eye movement exam in addition to the irregular parts of the exam. So Why do we care about posterior circulation strokes? Well, because remember, they're 20% of the strokes we're going to see. And you can get if you don't recognize this, you get a delay in treatment and evaluation. In a large study of over 70,000 patients, about 12,000 of those were posterior circulation patients, but mean time and presentation to the emergency department was 170 minutes for the posterior circulation patients and 110 minutes for anterior circulation. They didn't recognize the importance, and people evaluating them at home or EMS did not recognize the significance of their posterior circulation issues. So almost 17% of the anterior circulation patients were treated with TPA, while it's only 9%. So about half were treated with TPA in the posterior circulation group. The NIHSS scores were less for the posterior circulation patients, but then they were for anterior circulation, and door to needle time was longer. So even so, they were less symptomatic and given lower NIHSS scores, which probably contributed to their not getting TPA quickly enough. And of course, we all know that we need to get that in a rapid period. Now, pre-hospital wise, another study showed that in 750 patients who were studied over a 2-year period, 62% were correctly identified as having a stroke, but 38% were missed. But no patients with unilateral weakness, facial weakness, or speech problems were missed, which means that even though 40% of the strokes, almost 40% of the strokes were missed, the ones that presented with middle cerebral artery symptoms were picked up. The most common symptoms missed, though, were diffuse bilateral weakness, dizziness, and headache. So those are all posterior circulation symptoms, and so we need to pick up on that. Another study showed that in the same kind of thing, that symptoms associated with a misdiagnosis of stroke were dizziness, nausea, and vomiting, and that gaze preference, if you noted their gaze preference, that lowered the odds of missing the diagnosis. So we have interpreted this to mean we need to look at more than the old FAST exam, which is why we went to the BFAST exam. So B is for balance. So loss of balance, coordination, you could say vertigo as well. If someone is complaining of severe dizziness, and I don't want you to stand them up and see if they can walk. That's not what I'm saying. You can assume that that means that they have lost their balance and coordination. Loss of vision or visual field, and you have to be able to examine them. That we'll talk about that in a minute. So balance and eyes, the B and the E, have been added to the FAST exam. The FAST exam: face, abnormal unilateral weakness and drooping; arms, abnormal one arm drifts compared to the other; S, speech, abnormal slurred speech; T, time, waking with symptoms onset of time. That's what you need. And that is last known well time, important. Now, then we have you do, if they fail the BFAST, if any part of the BFAST is correct, then we have you do a Los Angeles motor scale. There's several scale systems out there. State of Washington neurology advisors decided upon the Los Angeles motor scale. And this is to determine, and it's generally accurate for middle cerebral artery territory strokes, which of course, involves about 60% of your strokes. You look again at facial droop, absent or present, it gets 1 point for present. Arm drift, absent 0 points, drifts down 1, falls rapidly, or just completely flops. That's then a 2. Grip strength is normal, 0. Weak grip strength, 1. No grip strength, 2. So interestingly enough, the Lamb score looks at only upper extremities and facial droop. Now, we'll talk in a minute where we go with the Lamb score. Now, best gaze, and the emergency physicians are going to do a much more in-depth eye exam. But if the patient says, I can't see, I'm seeing double, I'm having terrible time with my vision right now, check their eye movement. So, and we're looking at horizontal movement, and if they have, so have them track your finger, just have them look from side to side in a horizontal plane. If they have normal movements, that's a 0. If they have partial gaze palsy, which means the eyes do not track together, and so you'll end up getting double vision at some level of that motion of following your finger. Or if they have forced deviation, their eyes are always looking one way, looking to the right or to the left, or total weakness of movement of the eyes. Visual fields, you can do a real quick visual field check. Once again, checking to see if someone is, if they say I don't have my vision, I'm not seeing completely. I don't need you to do a full sector evaluations, but have them ask a person if they're cooperative, ask them to look at your nose, and then and you're a few feet away from them, and wiggle your fingers, bring your hands around from behind the side of their head, and ask when they first start to see. Now, you can also cover one eye and see if they see out of it. That'll tell you if one eye is blind or not. Cover the other eye, same thing. Just do a very quick evaluation. We're not expecting, and sometimes just reporting that they have, that they say that they have diplopia. Now, some of our stroke management issues, potential problems, paralysis of airway structures, vomiting, especially with hemorrhagic stroke, the nausea is associated with that. Always, anyone who's also vertiginous is also very often nauseated. Coma, seizures, and cervical trauma when patients fall suddenly. Breathing problems, they can have irregular respiratory pattern, chain strokes, breathing, or central neurogenic hyperventilation, chain strokes, stack breathing, where they breathe deeply and rapidly, and then it falls off as they blow off the CO2. Central neurogenic hyperventilation, they continue to hyperventilate, which is no longer being driven by their CO2. Paralysis, you can have total paralysis of muscles of respiration, which means you'd have to ventilate for them. So stroke management, manage breathing issues aggressively, consider RSI and an ET tube early as needed if you need to protect that airway or to ventilate them appropriately, and oxygen. Circulation potential problems include hypertension, hypertensive crises, hypotension and shock, and dysrhythms. Now, on your stroke CVA protocol for Clark County, we start out right from the top: universal patient care, alter mental status guidelines, including blood glucose. Balance, I'd like probably a 12 lead on all these people as well, or at least a 4 lead looking for atrial fibrillation, etc. On your BFAST exam, so balance, sudden loss of balance or coordination, eyes, loss of vision in one or both eyes, or other eye findings that we just spoke to, lack of facial symmetry, arm drift, speech not being able to repeat a simple phrase without slurring, or memory loss. So that may be aphasia. So it may be aphasia at that point. Note time lost, normal, time awoken, time of symptom onset. Now that's very, very important, because we're gonna time most of our treatments based on last known normal or well. Then the Los Angeles Motor Scale, which we've gone over before. Highest number you could get is 7. If a bleed is suspected, maintain normal ventilation rates and target EtCO2 of 35. Titrate O2 at the lowest level to achieve an SpO2 of 94 to 98. And also maintain EtCO2 somewhere in the 35 range, 35 to 40. If the patient's conscious, reassure them. They can hear, understand, even though they might appear confused or comatose. Transport emergently if the patient meets the following criteria: any positive BFAST findings less than 24 hours, critical, profound paralysis, aphasia, and comatose. Notify receiving facility of a code 3 stroke alert. Now, Peace Health Southwest will be the destination hospital for severe strokes, strokes that are felt to be probably middle cerebral and profoundly affected, persons who are paralyzed, aphasic, comatose, and consider the ones who, the positive Bs can go to either hospital if it's within the time limit. So Peace Health gets any patient with a LAM score of 4 or 5, because that patient is likely going to get interventional therapy treatment in the cath lab, more likely to. Any patient 80 years or greater, because they also will be if there's anything to treat, if there's a way to treat them, they probably will also need to have direct intervention. Symptoms more than 3 hours, but less than 24 hours. As you recall, even up to 4 or 5 years ago, we were stopping interventional treatments at about 4.5 hours after the last known well. We've now moved that out to at least 24 hours in many cases. So, but those patients require the services of a neurointerventionalist, which is only at Southwest. Suspected intracranial hemorrhage, including aneurysm or intracranial hypertensive hemorrhage, And that's because these need neurosurgical consultation at the least. Patients with profound paralysis, aphasia, or comatose, because they also will require interventional therapy if appropriate. Now, anyone with symptoms 3 hours or less and they don't meet those above criteria, go to the closest stroke center or the stroke center of their choice. Now, and it's just a reminder that in the past, Salmon Creek has been the preferred hospital for strokes for Kaiser patients, but Kaiser has now switched over again to P South Southwest, and so those patients would be best advised to go to P South Southwest because of insurance consideration. Now, remember, you're going to get some information at the scene, and usually it's pretty accurate, but the stroke team may require further medical history from the patient's caregiver or family members. So we'd like them to be there when the patient arrives at the hospital. Of course, that's a problem now with COVID, and that's been a problem. If this is not feasible, get a phone number that may be used by the stroke team for further, and have the patient have that family member or caregiver sit next to the phone waiting for that call. Now, we use Pulsera to notify, and the important data points in Pulsera are the last known well time, and also to have the contact info for the individual. Now, you don't have to put that in the Pulsera, but have that available to give to the nurse and physician. Document BFAST, and if appropriate, LAMS. You don't do a LAMS on every case, but if you have a positive BFAST, you need to document the LAMS. Any registration info, and they greatly appreciate if you can take a picture of their driver's license, etc. And then be sure to hit activate at the end of the Pulsera documentation. The newest form of Pulsera requires activate. Okay, current stroke data. I only have Peace Health data for the last year because we didn't get the upgrade from Legacy as yet. But these are the code 3 strokes that are coming in, and the percent upgraded, the number upgraded, and then the percent upgraded. And you can see we've been doing very, very well, and these are upgraded by the emergency physician after initial evaluation. You bring them in code 3 stroke, and they will, as quickly as possible, which is usually a few minutes, go in and do their initial evaluation, including an NHISS scoring, and then, if appropriate, they will upgrade those patients to what are called Neuro 911, which means they get the full bore stroke treatment. They move to the top of the queue for CTs and for CTA and all the lab and et cetera, and move right into getting TPA. Now, we've had as much as 92% of your code 3 stroke alerts converted to 911 upgrades, which means your field diagnostic skill is very, very good. Around the country, the last study I saw, seeing how EMS were comparing to an emergency or department evaluation of of stroke severity is that it was not that high. It was perhaps 50%. So you're doing very well. Anything from right around 70% to 90%. Your diagnoses meets the ED diagnosis, and also this to me indicates that you are doing pretty well at finding last known well, because that's the other thing that the physician will is whether they how rapidly they move them into the queue. Now, our door to needle time, we had a little glitch in May, and my memory is failing me as to why that happened. I think it was a couple of outlier patients, but our door to needle time, the goal is 60 minutes, and you can see the goal, the door to needle time is clicking, averaging right about that. The median time is well below the 60 minutes. Okay. Mark, are there any questions in the chat or anything that came up?
Nope, nothing that I've seen.
Okay. All right. Now I'm going to go into their pandemic treat and release protocol that we've been both, and I guess the preface for that is that with COVID and with the current Delta variant, the hospitals are quite, they're not overwhelmed yet, but they're quite backed up with COVID patients. As of yesterday, when I looked at the statistics, between the two hospitals in Clark County, there were 155 patients with COVID in the hospital, 42 of which were in the ICU, and 38 of those were on ventilators. Now that's an extreme amount. And then the EDs, whereas the ED volumes are not as great as they have been in the past, the time to be seen and the wait in the waiting rooms and it depend on the availability of beds. And because there's so many patients that are now being boarded in the emergency department because they either can't get a bed upstairs, there's not a bed available, we're full, or they can't get to an ICU because they're full. Both of Peace Health's ICUs are full of COVID patients and non-COVID patients, and they've added a third ICU now. They seem to have enough nurses for this right now, but that's because of providing travelers. The EDs, it moves very slowly because up 14 to 20 of the ED beds at any one time at either place are full of patients waiting to be admitted. They're keeping behavioral health patients who test positive for COVID because they can't go anyplace else. They're keeping patients who need ICU beds because they can't get into an ICU bed yet. The net effect is that the wait times in the emergency, but if you have a non-emergent, a worried well problem, a non-emergent problem, you're going to be in the waiting room for a long time, and that's reflective of the fact there's a lot of left without being seen, and so the system is straining at the edges. Now, the purpose of a treat and release protocol is not to tell people to go to the emergency department, but the net effect is to decrease transmission of known or suspected COVID, increase the safety of all patients, EMS personnel, and hospital staff, and to preserve some resources needed for critically ill patients, such as the ICUs. You've probably been following the news, and there are places in this country now where you cannot get an ICU bed because they're all taken up. Basic algorithm for a treat and release of anything is initial assessment, but then if it's a known or suspected COVID-19 patient, and then limit your number of providers yourself assessing the patient. And this is our assessment. And you say, well, when would I? Okay, you're going to assess all people who tell you that they have COVID or that they are worried they have COVID, they have symptoms of it, they have possibly been exposed, they have a family member, they have an associate who has tested positive for COVID. There's, on the right-hand side of the thing, there's the what to do with you have when a patient is in a care facility and they already have, or they're at home and they present you with DNR comfort measure only on a post. So if the post indicates comfort measures, unless the decision maker for that patient thinks that that patient needs to have some evaluation, then you do your assessment, discuss with the patient or decision maker, and we have a script coming up, and give them other resources and discuss that really there's nothing that's going to happen at the hospital. We're not going to take someone who has a pulse causing that says comfort measures only or DNR. We're not going to put them on a respirator. We're probably not going to treat them with massive doses of steroids, etc., in the emergency in the hospital. Now, for patients who don't have that pulsed kind of form, you need to do your initial evaluation. And if the patient gets full usual treatment, they will get full usual treatment if they meet inclusion criteria such as, first of all, the patient has to be between 18 and under 60 years of age. So anyone over 60 needs to, and who is having complaints and symptoms, needs to probably be recommended to go to the hospital, to go to the emergency department. Their vital signs are abnormal. So vital signs should be respiratory rate greater than 10, less than 20, heart rate equal or less than 110, systolic blood pressure equal or greater than 110, SpA02 equal or greater than 94. Patient has to be able to ambulate. Patient has to have decision-making capacity. You can't, they can't make, they have to be able to make those decisions for themselves. They cannot have syncope, cannot have ultramental status, history of diabetes, congestive failure, COPD, asthma, immunocompromised, or currently pregnant. Those are all high concern, high risk, or concerned by on-scene EMS personnel that it would be unsafe to leave that patient there because they don't have assistance, they don't have ways to take care of themselves. So if the patient has any of the exclusion criteria or fails any of the vital signs, etc., then proceed as usual. manage that patient as you would normally do, and then transport them. If they have passed all these things, they don't have any of the exclusion criteria, they're not, in your opinion, high risk, they don't have any high risk signs or symptoms, their O2s are 94% and better, then that's the kind of patient we will discuss with them whether they should go to the emergency department, whether they really want to go to the emergency department, or if they want to continue treatment at home and follow up with their own physician or with physicians that we will, or health facilities that we can hook them up with by a script. Now, sometimes the patient will say, well, how long do you think I'll have to wait at the emergency department? If you bring a patient in who has significant symptoms, that patient's going to be seen as quickly as possible by the physician, embedded as soon as. If you bring a patient into either of the hospitals now with minimal symptoms and no critical findings, they will likely be in the waiting room for a while because they won't have a bed to go in. And you can certainly advise the patient of that. You might ask them if they've already talked to their physician or if they've already talked to anyone about it. So if they don't have any of the critical symptoms, if they don't need to have usual, or if you're thinking, well, gee, you really don't need to go to the hospital, complete the assessment, discuss with the patient. We're going to go to the script in a minute, and connect to other resources. We have a home care pack, which we did not include today because it's not something you need to remember. It's a home care pack that's handed out. It has a list of resources. It has some basic directions on how to take care of yourself. It has a list of resources that they can call and maybe even get an online video management with, and also reminds them to if anything gets worse, to call 911. Now, if the patient or the decision maker says, I need to go to the hospital, then you can, if you think, well, this is really not going to be a good thing for the patient, you can then call online medical control to discuss this, and they can talk with the patient over the phone. So this is the script, and you can read that to the patient or hand it to them and read it and say if you understand this. So it basically says, we understand your desire to go to the ED, but now it's needed for really critically ill. In addition, it puts you and other people at increased risk of transmitting and or catching COVID. A lot of patients lately, again, have been opting to not go to the emergency department because they're worried about the Delta variant. They're worried about getting it again. And then typical script says, recommending you stay at home doesn't mean that nothing's wrong, but there's very little that an emergency department can do at this point. We want you to have follow-up care, here are urgent care clinics, etc. And then watch out for worsening shortness of breath, inability to walk across the room. If you have more questions, I can talk to the emergency doctor right now. That gives them the option. And then there's a comfort care one too. So the script, which you can read, we've gone through the numbers. We're kind of guessing right now that the number that in our total system, there are maybe 3 or 4 patients a day right now that might fit this category. That's not an overwhelming number, and but it's the worried well, and the, if the patient is absolutely adamant that they have to go to the hospital, we will never say no, you can't go to the hospital. Our best advice, though, would be that this is probably not in your best interest, and most of the time, I suspect these patients will self-identify and say, "What do you think? Do you think I should go to the emergency department?" And so this now, if they agree, say, "No, I'm not going to go," you will have them sign a release that they choose not to be transported, just like any case. All right. I think that's the end of it. I suspect there are questions on that, which I'll be happy to field at this point. Hearing none.
Hey, Dr. Whitwer, Rob Milano.
Hi, Rob.
Hey, so in regards to these patient categories that we're going to treat, or do the consults from home, the refusal, kind of some questions that have come up around, our stations with this as we've been discussing it, is that some of these patients aren't really refusing transport like they want to, and we're telling them that they can't go. So how can we document that differently or communicate differently with that patient? Because the refusal form is pretty specific in regards to that they're refusing that care.
I think in that case, you are not truly refusing to transport them as much as you're advising them that this is probably not in their best interest to do so. And if they, I don't know that we're at the, I don't know we're at the position yet where we would absolutely tell someone they can't go unless someone is so blatantly unless somebody is so blatantly violating our the system, saying, if they have no significant findings other than the fact they feel nauseated. I mean, one of the things that is critical is people who have not been able to eat or keep anything down, any fluids down. So that's, the patient may only have that as a complaint, and you probably, you would probably end up transporting them because, that's although not a critical symptom, it's certainly a symptom that would encourage you at least to get some IV fluids into the patient. So anybody who falls into if you have to, so it's going to be, I think the best approach is to say, well, we won't we're not going to not transport you, but we're advising that you consider that you don't want to, that you shouldn't go to the emergency department because you're going to be exposed to a lot of people who have it, who probably have. We're by the way, we're at right now about 12% positive on the asymptomatic patients in the that are tested in the emergency department. So there's a lot of asymptomatic COVID spreaders out there, and they're there in the emergency department for other things than COVID. I think it's more of a finesse of saying, gee, this doesn't seem terrible. Have you done these things and these things? Have you talked to your doctor? Have you talked to anything about this? If you go to the emergency department, it's not advisable. There's a lot of sick people there and a lot of people with COVID that you get exposed to. And if we transport you by ambulance, you're probably in for a long wait. And then if
So, Dr. Whitwer, Eric Simica had a question about when this protocol is in effect.
Well, it's probably in effect as soon as you view this. Now, I'm hoping that the numbers start dropping off this week. It appears that they were dropping off a little bit last week. If the numbers start dropping off, then we may be skating out of this this little surge of patients. So I would say that first of all, you're going to have to circulate. This has been circulated before, but it's going to have to be reiterated, and I think we'll probably have to see that people see this presentation again, and they have a little bit more familiarity with it. And if you're aware of this right now and you have someone who says, hey, do you think I should go to the emergency department or not? A lot of times they're calling you, in that case, you could say, well, I think, that, it'd be a better option to stay at home and treat yourself. And if you get worse, to call 911 again. Essentially, that's what they're doing. They're discharging people from the emergency department, sometimes from the waiting room and registration desk, without any further intervention. I would say that if you get a patient who absolutely says, I am going to go to the hospital, we don't ever say you are not going to the hospital, except maybe for some of our frequent flyer patients who fit a totally different category. So when is the protocol in effect? I suppose it could be in effect as soon as you have viewed this, and if you come up to a patient who fits this criteria. The same criteria, by the way, is that we want you to use to evaluate a patient to see whether they're seriously ill or potentially ill with COVID, which means that it's a tool for evaluation and criteria for what really constitutes sick. And it's fine with me for you, after you go through all this stuff, to say to the patient, well, you don't really seem to be that ill. I understand you're feeling uncomfortable, but here's what happens if you go to the emergency department. And if I know we've had enough patients who have bounced back from the hospitals after being sent home from the emergency department and come back really sick the next day or 2 days. So I would never have you absolutely refuse someone who's insisting on evaluation, if it's for COVID or whatever.
Any other questions for Dr. Whitwer? Okay, well, that's it for what was in the chat.
Okay. All right, good. All right, I guess the next thing will be Dr. Gadbois' case reviews, the last or the fourth Tuesday.
Yep, 2 weeks from today.
Thank you.
Thanks everyone for coming.